My name's Guy Goodwin. I'm Emeritus Professor of Psychiatry at the University of Oxford, and I want to talk to you today about psychopharmacology and medication-induced side effects. Now, to start with, we need a little bit of the right terminology. It is conventional to describe adverse reactions as things that are reported by the patients after they start taking medications, and adverse effects as being the measured consequences that sometimes result from taking medications, which can be regarded as unwanted or undesirable. These are often lumped together as the term side effects, but it's worth noticing that there is an important difference between them. One is largely subjective and dependent very much on what the patient tells you, and the other one is measured and is sometimes up to you to detect as a clinician. The measurement of these adverse effects is important. They are most valid in drug and placebo designs because under those conditions, the patients cannot, perhaps wrongly, attribute effects they experience to an active drug. They don't know whether they're taking an active drug, and so in a sense, the difference between the two groups is the only true measure of side effects attributable to the drug. That's the point of placebo-controlled trials. However, there's also an important issue around the spontaneity with which people actually are likely to report these effects. Some people are much more likely than others to report things, and it is generally true that in order to get a sense of the maximum frequency of side effects, you have to directly ask about them. The best example of that, for example, is sexual dysfunction. People may be a little reserved in wanting to talk about that. They may not spontaneously say that there are difficulties, but if you ask them, they may be very willing to tell you that there are problems. So again, the responsibility to some extent rests on you, even when the reported side effects are subjective. The other difficulty with that is that, of course, if you ask about side effects, you can inflate the numbers of replies because people want to please you and they may think that you want to give them the right answer. So that is something that we have to be aware of when we estimate the frequency with which we experience side effects. And you have to notice that in placebo-controlled trials, many side effects are attributed to the medication when it is actually a placebo. And this is sometimes called an attribution bias. So when people are taking a drug, bad things happen, they tend to relate the two. So these are some of the limitations on measurements, but nevertheless measurement is important. The next issue is whether or not the adverse effects are attributable directly to the effect of the medication. We're used to thinking about a mechanism of action. So for example, a medication that blocks serotonergic receptors or histaminergic receptors may be an effective drug for psychosis, but at the same time, those effects may lead to other adverse effects, for example, weight gain. So there are examples where efficacy is inevitably related to these side effects that are otherwise undesirable. And this can be a clear problem because it's very hard to dissociate the two things. On the other hand, there may be side effects or adverse effects that are entirely dissociable from efficacy. And a good example of that would be the prolongation of the QT interval, which occurs sometimes with drugs, particularly in the class used to treat psychosis. So we have to be aware of that distinction as well. In general, it's more problematic when side effects are related to efficacy, as you will obviously see. Now, when are we likely to see adverse reactions? There is a general finding that they usually increase with dose. They are often important because they limit the acceptability or the adherence to the medication by patients. And they are of particular importance when medications are offered in the long term to patients. And in many respects, that puts a big responsibility on us to explain to patients what the costs and the benefits of taking any medication are. We have to anticipate those things, and for example, if weight gain is a problem, then it may be important to really emphasize weight control as part of your management plan. So include adverse effects as an important part of the message that you're giving to patients. Manage their expectations and make sure that they're happy with the compromise they have to make between efficacy on the one hand and adverse effects on the other. And always remember that as a clinician, it's very easy to make that trade-off because we don't get the side effects. We just emphasize the efficacy. So always listen to what the patient is telling you in this area. So measure the right things and follow guidelines, which will usually tell you what those are and when to do it. Listen to what the patient tells you. Inform them about the problems that they're likely to have so that they can anticipate them and to some extent mitigate them. And have a clear understanding of the risk-benefit as you are a prescriber. So if you're thinking about lithium, there are major benefits, and you've got to weigh those against the belief that renal function is often impaired. Get the relative risks right in your own mind, and then you can communicate those to the patients. Serotonergic drugs that I've already described, weight gain, again, get a sense of what that means to the patient, get a sense of what the right trade-off is. And then finally, bear in mind that stopping medications can be problematic. You can get withdrawal symptoms which are usually modest, but can seem a big deal to the patient. And I think the essence of that is tapering medications off slowly, explaining what the likely effects are, making the context for the patient understandable, and then managing what happens subsequently and being sympathetic when things are worse than expected. Thank you very much for your attention.